Hello, everyone. Very warm good afternoon to one and all. And this is the second session of our MedTalk, where we have invited Dr. Ellen Pereira today to talk about allergy in a pediatric population. So I think it has been a lot of into the discussions right now. We see in a lot of forums that allergy and also the associated diseases, the hypersensitivities have increased, and the patient load also, basically, if we see or if we talk about different types of reasons which are associated with the allergy. So I think this is the right time, probably, when we should talk more about it. And as Metropolis, we welcome you all on this event. And I will share a short introduction of Dr. Pereira. Allow me to share my screen. Yeah. Yeah. So Dr. Alan Pereira is MD Pediatrics, and he has done his fellowship in allergy and clinical immunology. He has done his MBBS and MD from D.Y. Patil Medical College, MBBS from KJ Somaiya. And his current engagement is with Children's Hospital Mumbai as a consultant pediatrician and allergist. And he's jointly managing the general pediatrics and PICU as well. And he conducts a lot of allergy testing as well as immunotherapy. He has been participating in a lot of conferences, workshops, and he has been a bit enthusiastic in conducting the allergy testing as well as talking about it. So today we have invited him as our guest. So yeah, over to you, Dr. Pereira. I think you can start sharing your screen, and yeah, thanks.
Okay, thank you. Thanks for those kind words. I hope I'm audible to all of you.
Yes.
Okay, yeah, okay. So yeah, as we know, this allergy is something which is coming up, is actually happening. It is almost taken over the role of a pandemic, which we are seeing, and it is not something that is affecting only children or only the geriatric age group, but it is all over the age spectrum, right from infancy right up to the geriatric age group. The manifestations of allergy is different for a different person who may be allergic to the same thing. And it is the wow that and the WHO have said that allergies is one of the most common chronic diseases that we are facing, and it is showing an upward trend. We all know what allergy is, that it is basically an immediate type 1 hypersensitivity reaction which is there, and it happens after exposure to a specific allergen. After a person is exposed to a specific allergen, the body goes ahead and starts developing an IgE, which is primed, which binds to the mast cells later on a second exposure, and then it releases the chemicals which are responsible for the clinical manifestation. Now we know allergy is not something that is limited to one organ or limited to one symptom. It can affect almost every part of the body. So if the lungs, you'll get the features of asthma. You'll have features of allergic rhinoconjunctivitis, atopic eczema, GI symptoms. We tend to quite often ignore the GI symptoms because they can be very subtle. It may just be a bit of stomach discomfort, a bit of stomach pain on and off, feeling of bloatedness. Now, even we consider migraines to be a manifestation of atopy. So that is again something which we have to keep in mind. So what is an allergy? Very simply put, allergy is the abnormal reaction of a body to something which is very innocent, something which the body should not be reacting to. So what I tell my patients is, like, if you have a neighbor, every time you see the neighbor, you get angry. Every time you see a neighbor, you start reacting, which is not supposed to be happening because it's a neighbor. He's not coming to harm. So similarly, an allergy reaction, uh, because of that, there is an activation of your blood cells. That is your basophils, which finally results in an increase of IgE. Mast cells are required to be activated by that specific IgE, and when they release certain chemotactic factors and chemokines such as your histamine and other things which go ahead and cause the clinical manifestation. So as said before, allergy can manifest in various forms. Just a child or an adult who has red eyes on and off, watering of eyes. In infants, we very find this very commonly. They will come with red, rough cheeks. So that is again, you can have a rash. You can have angioedema that will come with a swelling. So all these are various manifestations of different allergies which can come at various ages. Now, is allergy and atopy the same? Atopy refers to the genetic tendency of developing an allergy. So we generally see a patient who has allergic rhinitis or urticaria, and we say they're atopic. Yeah, they're atopic, but once you have a clinical manifestation, then they become allergic. So atopy is just the genetic predisposition. As so those people are more predisposed to being sensitized to one or many allergens. So either they'll be monosensitized or polysensitized. Now, when that sensitization results in clinical manifestation, then it is an allergy. So when we see a report, we get a long list of things which may be positive. So you have a patient who may be positive to dust mites, to milk, to eggs, but the patient may not be allergic to all of it. So again, we have to come down to the most important thing, that is history. So your testing as well as interpretation of those tests has to always be in coordination with the patient's history and patient symptoms. Again, we have a question which all of us face, like if the child is an asthmatic wheezer or an allergic rhinitis, they will say, "Will my next child have?" Or the father will say, "I am allergic," or mother will say, "I have asthma. Is it because of me the child has got?" We have to remember that atopy, or the tendency to get an allergy, is inherited to some extent. It is not always 100% inherited. But to develop an allergy, you need to have those particular susceptible genes and an environment. Once these two things come together, then the person becomes allergic. So basically, what is means we already spoke about what is atopy, but then what are the most common manifestations which we see? So we see eczema, which is one of the most commonest things, especially in younger children. As seen over here, the infant will have red, rough cheeks. So, if it is allergic to milk, sometimes the mother will also tell you the history that, soon as he drinks milk or a little bit of milk trickles down his face, he'll develop red rash along the line where it trickled down. Some of them may have very repeated and difficult to settle diaper rash. They will have a lot of irritability. They'll be crying a lot of irritability. So those things may point towards something such as a milk allergy. Allergic rhinitis is again very commonly seen. It starts in the first few years of life, around 3 to 5 years. That's when your allergic rhinitis starts. The mother will come complaining that the child keeps having cold with every season change. Unfortunately, they'll blame it on, they'll say the child is allergic to monsoons or allergic to winter, or they'll say कि नहीं उसने कुछ ठंडा खा लिया, that is why. So again, what we have seen is between allergy and atopy. So as explained before, your atopy is your genetic tendency, so to have an exaggerated response, and allergy is your clinical manifestations of those exaggerated response to something which is not harmful to the body. So now, why are we talking about eczema and asthma and everything down in the same topic, in the same thing? We have to realize that today's eczema may down the line somewhere develop asthma. So that is what we call as the allergic march. So quite often we tell the mother, we tell the child, okay, child only has eczema, it will clear out in some time. You don't have to worry about anything. But we have to keep in mind that, okay, if this child is coming to you later on with frequent colds or frequent coughs, he may already be on the path to having asthma or allergic asthma. So allergic eczema is the first step, which is something which is very important for us to recognize early. And almost one third of the children, almost 30% of the children tend to become asthmatic later in life. And the incidence of allergic rhinitis in adults with allergic asthma is almost 75 to 80%. So this is the graph that we talk about as the allergic march that is there. So the atopic dermatitis that comes in is very early in life. The first few months of life is something which we should always examine the child, touch the child's cheek. Mother will keep saying, "Nee, abhi thandi hai, that's why it is there," or "I have not put moisturizer." But we have to learn to identify the signs of inflammation which is there because of atopic dermatitis. Food allergies also do tend to occur early in infants. It is not something which is there only in adults. Quite often we'll have parents or we'll have adults saying, "Ki, nahi, I am eating this from from my entire life." You have to remember food allergies can occur at any age, though we see like certain things occur at certain ages, which is more commonly seen. Like milk usually starts presenting early in life in infancy in the first few months. Then you can get egg allergy that comes in later on. Nuts and fish too tend to occur later on, but yeah, we do see them even in children. So, as said before, today's atopic dermatitis, then they start developing allergic rhinitis at around 0 to 5 years, and even they can also go ahead and start and develop allergic asthma. Again, the misconception which we see in our country is that asthma is supposed to be a disease or a problem only of adulthood or of adults. We have to realize and remember that asthma is very common in children. Studies are showing that almost 7 to 11% of Indians have it. So if you see this group, you have a peak incidence at around 4 to 7 years. So that is a time when child is going to school, when child is in new environments. So apart from repeated virals, asthma can be a very a very common cause for repeated coughs. So what are we trying to do? So earlier we learned to identify eczema. We learn to identify the cause of it. That's where we can come in, we can intervene because we all know skin is the largest organ. It has our body surface area is very large. So imagine your because of the eczema, what we can see may be localized, but that same filgrastim deficiencies, the dry skin, is throughout the body. So they have the protective barrier is what is destroyed or what is affected, and that gives easier chances for allergens to enter into the body and trigger the immune response. So once you identify eczema, you identify the cause, you teach the parents how to intervene, what kind of soaps to use, what kind of moisturizers to use. So we try and bring that down. So we'll have a bit of reduction in rhinitis. And overall, our aim is to decrease the long-term morbidity and long-term effects of this disease. Now, this slide, if you see, is something which we all try to understand or we all try to explain to parents as to why a child, even though he's allergic to something, maybe this is dust mite or mold, has seasonal fluctuations. We have to understand that most of the patients are polysensitized. So you have to imagine that like a couple of blocks or maybe 4 or 5 blocks stacked upon each other. So only when the blocks cross the symptom threshold will the patient start showing symptoms. So like if you see this patient who's allergic to dust mite and mold, maybe this patient is living in a humid area or the house has mold on the walls and they're keeping the house nice and warm so the dust mites are persistent, that is perennial. But he's also allergic to seasonal pollens such as birch and ragweed. So during that time when the birch pollens are high in the environment, the patient crosses the symptom threshold. That's when the patient will start having symptoms. Maybe he may be having asthma or maybe having rhinitis or maybe itching of eyes. And as the season ends towards July, the patient improves. Same thing happens during November. So depending upon your local geography, depending upon the patient, whether the patient is polysensitized or monosensitized, The symptom threshold is very important because even when we treat, if you're looking at a polysensitized patient, we know that if we treat even one or two of all this polysensitized, the entire stack of blocks collapses. So the patient is always below the symptom threshold and the patient is always clinically better. So again, okay, so why are we testing on the, why are we talking about CRD today? Why are we talking about allergy testing? Is that quite commonly a certain allergen can have a cross reaction with other allergens which are there. So at least being from Bombay, most commonly what I see is dust mites. So dust mites, the body shell of the dust mites, the exoskeleton of the dust mites, they share certain proteins which are seen in other things such as shellfish and mainly cockroaches. So for us, cockroaches cross-reacting with shellfish, cross-reacting with dust mites is very common for us. So when we are doing certain tests, if I'm doing an SPT, I may get all three or four form. Again, we come down to history first, talk to the patient, find out about is the patient vegetarian, non-vegetarian, what about cockroaches in the patient's house? Are they doing uh, are they doing pest control? So it helps us give such kind of advice, such kind of updates to the patient. When we're looking at tests such as CRD, it gives us the component level, it gives us the proteins which are there. So we'll see that later on how CRD helps us. Yeah. So again, in today's age and day, when we're talking about the diagnostic protocol which we do, everything, as I said, the first thing it always starts is with the proper clinical examination and a clinical history. A lot of our population think they are allergic. But when we actually see them, it is not as high as people's conception or people's perception of allergy. They think every viral illness is an allergic illness. Every cough cold is an allergic illness. So history, clinical examination, and importantly, temporal correlation between the exposure to the possible allergen and your onset of clinical symptoms, that has to be important. It cannot be that, okay, I ate such and such thing 3 days ago and today I'm having problems. Or I went to the garden on Sunday and on Thursday he started coughing. So the temporal relation is something which is very important. Once you establish through clinical examination and through history that the person may have an allergy, that's when we come in and we start talking about what kind of allergy tests are there, what is possible, what are the advantages of them, and what is specific to be given for that kind of patient. So skin prick test, which is there, is the age-old method. It is time-tested. It is the basis of allergic testing. So when we look at the WOW guidelines, skin prick test is still the gold standard of. There are a certain disadvantages that patients do ask us about, and because so they tend to be a little scared about it. But that's when again we reaffirm it. We talk to them that reactions can occur. It is not that every patient gets a reaction. Reaction can occur. They are rare, but you can control them. It's not always going to be a fatal reaction. Severe reactions are very, very, very rare. Again, the skin prick test has to be done by someone who's qualified, someone who's used to doing skin prick test, because the proficiency has to be there. So it requires a good procedure to be done. Reproducibility is poor if not done well, if not done properly, if not done by a trained person, if not done very well. Drug interactions, yes, that is a main problem, which a person or a patient or a child who's already on antihistaminics has to stop antihistaminics for a certain length of time, depending upon whether it is a first generation or second generation. If a patient has got severe eczema all over the body, we cannot do a SPT. Quantitative results, it gives us in terms of diameters. We do not have the exact IgE levels, but that again has its plus and minus. Total IgE testing, which we see is very commonly done. Now, that is something which we have to understand, that there we do not have a standardization of IG, especially in tropical countries like us. Again, around 30% of patients who have a normal IgE may actually be allergic, and they may be misguided saying that, okay, just because your IG is normal, you are not allergic, which is a very wrong thing to say. And apart from that, a lot of other infections, a lot of other viral infections can actually have or can actually influence the IgE levels. Now, when we look at other things, such as we get a lot of these kind of reports where they test for everything, right from paper dust. So in children, I see a lot of patients coming with paper dust. They come with chalk dust. They come with any kind of and every kind of things. So there are a lot of tests in the market which are done at a very cheap rate. They are not standardized. They are not evaluated. You'll have weird things in that, as I mentioned, chalk dust, paper dust. You'll have something which is full. You have to understand the difference between an irritant, something which is an allergen, and something which can have which can give contact reactions. So these are again the other tests which are done. That is your immunocap, which is the only gold standard test which is recognized by the WOW guidelines for the in vitro testings. Your ELISA and your RAST are no longer accepted. They can give us a lot of false positives, false negatives. So if specific IG has to be done, we have to insist that it is done by the immunocap method only. Now, when we are coming down to the mass blot versus the CRD, what is the major advantage of a CRD? So the major advantage of a CRD is, in a single blood sample, we are actually getting the entire around almost 300 possible allergic proteins which are there. So that is something which is the major advantage of the CRD, which is available in our country right now, is that in a single prick, in a single sample, you're getting almost 300 the 300 allergens. So this slide is giving us some information about the Metropolis lab, the study which they had done, which they have seen that in the age group of 0 to 3 years, the highest incidence was of cow milk and egg, which was said, which as I said earlier, these are the most common things which we get at this age. Other foods do come into during childhood, such as nuts, fish. Mold is very common. Again, we'll have to see as per where the person is and which part of the country is it a humid place. For Bombay, for me, any child who's school going above 6, 7 years or adults, most of them are allergic to dust mites. So DF and DP. So again, interestingly, the study which I had done along with one of my colleagues at Baruch, again we have seen that the household environment, your house practices, again tells you what kind of dust mites you may be allergic to. While in Bombay, I got a lot of DF and DP. In Baruch, you had a lot of Blomia, which is a storage mite, because they tend to have a lot of grains which they store for the entire year. So again, these are the various kinds of allergies or various kinds of tests which are done, which again we say is not really recommended, right? So with every test, there are plus points, there are minus points, and we have to again remember that till today we have not no technology can tell us why some patients who are allergic to a particular protein some may have a severe reaction and some may have a milder reaction. So to some extent, CRD is helping us crossing this gap which are there today. So when we are looking at allergen, I suppose that this is a peach which you're seeing. Sorry, I think it's an apple which you're seeing. It has hundreds and thousands of proteins, hundreds and thousands of molecules, but that doesn't mean each and every one of them is allergic. So you may have just 3 or 4 or maybe 5, 6 which are allergic. Not each and every one of them are allergic or possibly allergic. And it is not that every patient who is allergic to the fruit is allergic to each and every protein of that. So what we have done in terms of CRD, in terms of specific allergen components, is you take the entire fruit source, that is, it may be a nut or maybe an apple or maybe a pollen. Through that, you purify it to take out the allergen extract. Now we've further gone down and taken out the certain proteins which are there. And now they've further gone down and they've taken out the cross-reactive allergen proteins. So these are some of the most common things which you see. Like if you're seeing egg, can have GALD1. If you're seeing birch, you have wet wheat. You can have ARH2 in peanuts. So what happens is when you're looking at various components, all of them may have certain common allergenic proteins. So that manifests as a patient who's allergic to something but eats and like if you're allergic to peanut and and if you've eaten soy, you may have a reaction because of the common proteins which are there in between the cross-reactive components. More common than those, what we see is with regards to cockroaches, dust mites, and shellfish, that is either prawns or crabs or lobsters. Very commonly seen a patient who's allergic, has severe allergic rhinitis due to DF or DP. He goes to a restaurant, he has a prawn, or he start coughing, or he may start wheezing. Some of them may have a bit of abdominal pain. So you have to remember it can be because of cross reaction. CRD also tells us something which is very important, that is protein stability. So all proteins can be divided into something which we call as heat stable or heat resistant or acid resistant, and the other ones may be labile. Very commonly, again, we see this in milk in children who have got milk allergies. When we do a CRD and we know if it belongs to either the casein group or belongs to the whey group, we can tell parents, okay, fine, this is a heat labile protein. You heat the milk to a particular temperature for a particular amount of time, and we are actually destroying those proteins or breaking down those proteins, so that will be less allergenic or non-allergenic to your child. But if the CRD shows that no, the child is allergic to something which is heat stable, which is acid resistant or heat stable, no amount of heating or no amount of baking that particular milk, it will not make it non-allergenic. So that child is advised not to have milk in. So this slide again shows us that a heat labile protein has got less risk of severe symptoms, while a stable protein has got a very high risk. So in the era of CRD, we can actually help patients decide on how to mitigate the possibility of severe reaction. Again, what we see are heat labile proteins or acid labile proteins tend to have more of local reactions such as oral manifestations, your oral allergic syndromes, and stable proteins tend to have more of systemic reactions. They are the ones who have more chance of giving anaphylaxis. So, heat stable protein is something which you have to be all aware of, and it helps us give better advice to the patient. So, as technology has developed, as our testings have developed, we are all trying to go down to the most definitive diagnosis to give the most definitive treatment which is there. Uh, like I said before, you have thousands of proteins, out of which you'll have a few dozen allergenic proteins, and that patient may be allergic to just one protein. So that is why the global trend over which is there is going from extracts to coming down to the molecular level. So this is what they have tried to explain to us, that when you're looking at extract level, you'll have a lot of uh, cross reactivities. You'll have common carbohydrate derivatives. You will have certain proteins which may be degraded. So when you're doing an SPT, you may get a negative test because your prick solution has actually degraded over time. It is no longer allergenic, even though the patient is allergic to that thing. Certain proteins may actually be at a very poor or very low concentration. So you may get a false negative test. While at molecular level, you actually have each protein at an ideal concentration in the ideal state, which is available, which is there in the form where it is biologically active. So again, as we said, your molecular allergens increases your specificity. It tells you exactly which protein is positive in a particular allergen. It helps in today's day and age. Nothing can be done very well without an AI. So it is very high on the AI based of it. So what happens when you're using a extract base versus molecular allergens? We'll just go through few of them which are there. So false positives are very low in molecular base as compared to extract base. You can give some kind of prognosis, some kind of risk which is there to the patient. What is the risk of getting anaphylaxis? What is the risk of the patient being able to overcome the allergy by certain things such as boiling the food or cooking the food or certain fruits such as apple. If you have the allergenic protein which is there on the skin of the apple, you peel the apple and you will not have any symptoms. So all these things help us give individualized guidelines to the patient. Again, with it helps us know what kind of treatment to give. So if I'm seeing a patient with dust mite or maybe cockroach who are positive and it is a tropomycin, I may not tell the patient to go ahead with immunotherapy. So it helps us know which protein is positive, so we can give what kind of immunotherapy to give, whether will immunotherapy work in this patient. So that is the kind of information we get today and what we can give our patients today because of the CRT which is there. So overall, the CRD does help us differentiate between cross-reactivity. It gives us genuine reactions which are there. It can help predict the kind of reaction the patient would have on exposure to the various allergens which are there. So when we look at this report which is there, we are looking at a patient who is there. So this is the kind of report that we get through the CRD. Apart from giving us a level, it also gives us a color coding. So this helps us visually explain to the patient, like, okay, see the patient, I'm looking at dust mites for this patient. He has got a very high positivity. So this patient, you can tell them, okay, your major symptoms which are there are because of the dust mite which is there. So again, going back to history, if the patient has no GI symptoms, has no symptoms associated with food, so we'll tell them, okay, these like your fruits and vegetables are more of sensitization. They are not actually causing a problem to you. Your rhinitis, your snoring, your blocked nose is basically because of dust mites. And if it is seasonal, the tree pollens which are there are pushing it all up above the threshold, which is so here you see it again then subdivides it into DFDP and whether the patient is positive DER F2, DER P2, or DER P20. So we can come down to the molecule, which one is it positive, whether will immunotherapy work for it, will immunotherapy not work for it, whether it is a storage protein. So we know storage proteins can have a greater chance of systemic reaction. So the patient will be more careful with those things. So it gives a brief idea of what is there, what kind of symptoms the patient can have, which class of proteins it belongs to. So overall, CRD is very gives you a very exhaustive list of things, a very exhaustive amount of information which is there. So that is something which we sift through and it helps us counsel the patient. So what happens is if you're a patient who has got persistent allergic rhinitis symptoms or who may be snoring in the night, who may have allergic asthma. So depending upon you're doing an SPT, I will get an SPT positive. So then I really don't know based only on SPT will the patient respond to immunotherapy, but it does let me know, yeah, the patient is positive to dust mites. It gives the patient a visual thing. So basically, the patient sees that, okay, I have put a drop of DF or a DP or a Blomia solution. I've pricked the patient, and this is the kind of reaction. So patients start accepting the fact that, okay, yeah, it is causing an reaction on my hands, so similar reactions inside. But then what happens is we do a CRD. So if I know that, okay, my CRD is come positive to certain things such as DERP1 or DERP2, we know those patients are going to respond to AIT, that is immunotherapy. While other things such as DERP10, DERP20 are more of tropomycin. So the clinical response to AIT will be diminished. So those patients, we really think again before we go ahead and ask them to go ahead and take the full dose, means before we convince them a lot for the AIT. Similarly, things which we know that the DERPy 23 has more risk of asthma as compared to the DERPy 1, DERPy 2. Again, we know that when you have pet allergies which are there based upon the allergen which is there upon the kind of protein you're positive, we can advise whether we should go in for AIT, that is allergen immunotherapy, not to go in for it, whether something can be done about it. So this is the kind of information that we get from all of this, which is a very high, very detailed kind of information, and which helps us give better personalized treatment to them. So here, when we know a protein belongs to a certain class, such as your LTPs or belongs to your storage proteins, they are higher risk of having reactions. While as a CCD has a lower risk. So those kind of patients, we can tell them, okay, don't worry. While a patient has higher risk of having a reaction, higher risk of anaphylaxis, we have to give the patient that, okay, you have to carry adrenaline with you. You have to train the patient, train the parents or the caretakers, and tell them that wherever you're going, even if you're going by flight or going by train, this is what you carry, this is how you carry, this is how to recognize early symptoms. Because anaphylaxis doesn't always mean the patient having trouble breathing or falling unconscious. So again, this also slide tells us about risk stratification with regards to storage proteins being very high on the list and your CCDs being very low. So so you will tell a patient who has peanut allergy, who's allergic to ARH1, you will tell them avoid it at all cost. Carry an EpiPen with you, carry adrenaline with you. Heating, cooking, baking is not going to solve that problem. While a patient who has ARH8 has a lower potential. It doesn't mean he will not have a reaction, but the possibility is lower. So when we look at this, is a very concise thing about some of the few common allergens that we see. Like if I'm looking at again peanut, which as we seen earlier, ARAH1 has got high chances of anaphylaxis, very severe allergy reactions. H2 is also a storage protein, so they also have very high chances. While the profilin has a very low chance. If I'm looking at milk, we know casein is a very allergenic protein of that. So that the casein is not going to break down if you heat it, if you bake it. While your albumin is the one that is going to break down. And albumin, that is the thing which the patient will outgrow as the patient ages. So it also helps us tell us that, okay, fine, a child is allergic to milk, around 60-70% of them will outgrow by 1 year of age. And by 5 years, almost 95% are out. So, you don't really have to worry. So, as we said, allergy is something which is very specific. It is not specific to the person's family, but it is specific to the person, to the individual. So, twins may have also show difference in their manifestations of allergy to the similar protein. So, so earlier, once we would get an SPT positive, we would tell everybody, okay, now you have to go ahead and take AIT. In today's day and era, once you get an SPT positive, you go ahead, we do a CRD, then you go ahead and tell them, okay, fine, you belong to class 1, so your treatment is this is what you're getting. You belong to class 2, so this is the kind of treatment you're supposed to get. Or you belong to this class 3. So treatment is individualized to the person as well as individualized to the protein. So that is a match which is very important, which we get through CRD. So these are the few benefits which are there of doing CRD. That is, it brings down your cross reactions. It tells us about the severity which is there. It tells us about the likelihood of clinical manifestation. What is the possibility, or what are the likelihood of you developing anaphylaxis versus not developing anaphylaxis. How to overcome the allergy, what to do, who should get AIT, who should not get AIT. So overall, I think CRD is something which is a revolutionizing thing for us in our country in diagnosis of allergy. Though the baseline, the gold standard is SPT. Based on that, so SPT is basically a foundation. It is like you're building a building, so you have to have a very good foundation to make it strong. But Just a foundation does not equal a building. While a building without a foundation is weak. So using SPT, CRD gives us a lot of information. It gives us a lot of personalized treatment which we can. So I think so basically this is overall just in overview of CRD, and thank you for your patient listening.
Thank you so much, Dr. Pereira. I think it was an amazing narrative on entire CRD testing. And I think now I would request all the participants to please post their questions. So we will be happy to take them. We have some questions. Probably we can start with them. So, Dr. Pereira, I think you spoke about the increasing incidence of allergy, especially So, do you see that any role of changing environment is there now in the increased incidence of allergy?
See, we know allergies are multifactorial. It
Yeah.
is the susceptible genetics with the susceptible environment. The age-old study of the hygiene hypothesis has brought that very clearly that your environment does trigger or does influence your atopic genes, and it helps and clinical manifestation. So in today's age, we have a lot of pollution which worsens allergy. Every diesel particle increases your allergenicity of every pollen by up to 50 times. So a pollen which is allergic becomes 50 times more allergic because it has attached to a diesel particle. Similarly, weather change, your global warming has increased the pollination period of certain plants. Your use of chemicals, we have a lot of VOCs, that is volatile organic substances in our houses. We use a lot of floor cleaners, we're using a lot of gums, we're using MDF material for furniture. So those are the things that are which present in the environment is actually triggering a lot of problems.
Okay. Thanks. Great, Dr. Aaron. So, do you see that, how do you see that results of CRD when you compare it with the skin prick test? How much correlation do you see, and what do you generally suggest for what cases? Can you give some overview on that?
See, it is again a lot of things about what test you want to go for is something which I personally discuss with every patient. So it is not it's not a quite kind of a flow chart or kind of fixed regime that every patient has to do skin prick test only or has to do CRD only or has to do both. So multiple factors come in as for the age of the child. Are they comfortable doing a skin prick test for the child or no? Is the child cooperative? Are they okay with doing the immunocap because of the costing where they have to do an in vitro, or are they okay with doing a CRD? To what level do the parents also want kind of want information? So suppose I'm getting an SPT positive for milk, and the child is maybe 11 months old, I may say, okay, fine, you can wait for some time, child may outgrow it. But if a 5-year-old comes with positive for milk and has reactions for milk, I'll tell them, okay, we do a CRD, we'll know what we can avoid for the child in terms of milk, what to do. Similarly, if dust mites or cockroaches are there, we can tell the patient, okay, fine, you can take AIT. If I'm doing CRD, I know, okay, if I'm positive, if immunotherapy is going to help you, so it helps the patient decide rather than tell the patient to take immunotherapy for a year and then say, oh no, it could have just been a tropomycin. It's not helping you. Now you discontinue. That's
Agreed, correctly. I think that should be kept in mind for sure. So while we talk about that topic, one more clarification, if you can provide. There is one question. So, how do you approach the interpretation of allergy test in children where there are multiple allergies, which has conflicting outcomes? Uh, I mean, is it allergy or is it any other type of hypersensitivity or any mixture of that? How do you differentiate that?
see, as I said, it always has to come with exposure. It always has to come on history. So, like if again, it depends upon the age of the child, the geography of the child. Like if I am doing an SPT and if I get something a pollen positive, which is not in that area, we know it is a sensitization. If I'm getting DFDP positive in Bombay, I know that has got higher chances if the child has got stuffy nose at home. So those are the things. While so if the symptoms are indoors, we know it's more and more likely an indoor positive, the indoor allergen which is causing all the problems. If the child has more issues outdoors, we know that it is an outdoor allergen which is more likely to cause all these problems. So it all comes down back to history, comes down to examination, and as I said, temporal relation is very important. It cannot be that what you have eaten or you have gone to a friend's house who had a dog 3 days back and you start sneezing after a week and then blaming that dog because that's not the way it works.
Agreed, agreed. In fact, there is one question which is asking. So, what is the difference between, and how to differentiate between intolerance and allergy? How to know whether, in the pediatric population especially. Yeah.
So food intolerance, which you see, is basically not an allergic reaction. So even the quantity matters. While if an allergic reaction quantity doesn't matter, even a small amount of a person is severely allergic to something such as peanut, and you use the same spoon which you have maybe given a peanut chutney to someone else, and the same spoon you serve this person something, he may have a reaction. But intolerance depends also majorly on the quantity which is there. You may see delayed reactions with intolerance. So a lot of people do IgG for intolerance, but again, that is not something which is standardized. It is not something which is accepted. So IgG testings for intolerance is not something which is uh, what is it, we have any proof of or we have any supporting evidence for today. So intolerance, again, it comes down to identifying what he had or what he was exposed to, when was it, what was the onset of reaction, what kind of reaction was it.
Yes. Because we get a lot of cases, especially for milk, where is it a milk allergy, or it is a lactose intolerant, or is it a food intolerance to, specific type of milk? That becomes very
So
difficult.
again, the
What is that?
issue is a lot of people confuse between lactose intolerance and milk allergy. So they think everything is the same. You tell someone you're allergic to milk, you are allergic to milk. They say, oh, मतलब हम लोग दही दे सकते हैं, because in that you can give curds to a person who's lactose intolerant. So we have to explain to them that lactose intolerant has to do with the carbohydrate component. It is more of a enzyme deficiency, while allergy is to the protein component. It is more to do with the immunological side of it. So a lactose-free milk will work in someone who is lactose intolerant or milk intolerant, but lactose-free milk will not work in a patient who is milk allergic.
Yes, great. Thanks, Dr. Aaron. Let me see if there are any more questions. Yeah, there is one question. So, can you discuss the importance of involving parents or caregivers in the allergy testing process for children? And what advice would you give them, you know, to the caregivers and parents of the children? Yeah.
So again, as I said, in pediatrics, the decision makers are the parents. It is, I mean, where the child makes a decision in terms of being not willing to do the test, but being ready to do it, means willing to do it, wanting to do it comes from the parent side. So they are the decision makers, and unfortunately for us, the sufferer is the patient. I mean, the child. So the parent doesn't understand physically, doesn't go through what the child is going. So we have to explain to the parent what are our different options. So what are the advantages of skin prick test? What happens in the skin prick test? What are the advantages of immunocap or a CRD, and what is the process of that? Very often the parents get anxious in front of the child. Oh, you're going to take out blood, or oh, you're going to prick my child so many times, or itne chote bacche ka you're going to take out so much of blood. So looking at that reaction, the child already becomes anxious. So the parent has to calm down, parent has to understand it is for the child's benefit, and it is not something that's really going to harm the child. When you're looking at a blood test, most of them know that it is just a single prick, it gets done fast. When it is an SPT, we realize that okay, the parent is not anxious, the child is cool and calm. And nowadays, a lot of children, even though we are not, we all pediatricians talk about decreasing screen time, but one mobile with a good video and the child will do the full SPT without uttering a word.
That's true. That's true. I completely agree to that. So, any new emerging technologies which you see in coming future, which will make allergy testing and treatment more easier? Any updates, global updates?
So basically, what we are looking in terms of CRD is what is the latest thing which we have, which is globally available, is finally reached us now. Basophil activation test, that is a bad test, is something which hopefully does come up somewhere. That is something which is yet under research and under evolution. We don't know when it will come, but when it comes, it will revolutionize it to another level altogether. In treatment wise, yeah, we have come down to biologicals, we have come down to to IgEs, we are using omalizumabs. So overall, as we said, this is something we are not at the nascent phase, but we are still in the childhood phase of allergies and of treatment and diagnosing allergies. That is, we have a long way to go, and as things progress, as we learn more, we will see how. So we have a lot way to go right now.
Great, great, great. Thanks, Dr. Allen. I think there are no more questions. I would just request you to give a take-home message, I think, finally. So, you know what the young doctors who are there from MedEngage and also the pediatricians who have joined this webinar. So, any take-home message would you want to give it to them?
I think what we have to remember and is allergies are not all that uncommon. Allergies do happen. They can happen right from infancy to geriatric age group, different manifestations, and the person who's suffering only knows the problems that he's undergoing through for allergy. So it is not something we dismiss it. We have to keep it in our minds, and we have to do the right test for the right patient so we can give them the right treatment options.
Perfect. Thank you so much, Dr. Allen. I think it was a
Thank you.
very
Thank you.
engaging session. And thanks once again, everyone, for joining this webinar. And I hope it was helpful. So we would close it here if that's fine. And I think if you have any more questions, you can write it to us to our email address, and we will be happy to answer them later as well. Yeah. Thank you so much.
So thank you. Thanks for having me.
Thanks. Thank you.
Welcome.